This program was made possible with the generous support of the Magnolia of Millbrae. The Magnolia of Millbrae is a senior living community that provides a variety of services and amenities to its residents. For more information, call 650-697-7000 or visit their website at www.themagnolia.com. MCTV thanks them for their support.
Welcome to Wellness Update. My name is Sherry Plambeck. I'm the Director of Sales and Marketing at the Magnolia of Millbrae. We're a senior retirement community and we offer independent living and assisted living. We're located in Millbrae, California. Today our topic is importance of colorectal cancer screening. Our guest is Dr. Marna Skaar, a gastroenterologist practicing for over 20 years in San Mateo County and affiliated with Mills Peninsula Health Services. Dr. Skaar, welcome to our show today.
Thank you so much. I'm delighted to be here.
What is colorectal cancer screening?
Colorectal cancer screening is done in an individual who has no symptoms but has reached the age of 50. And because colon cancer is common, just as breast cancer is common, we do screenings for those particular cancers. In a typical life, there's a chance of 1 in 18 of developing colon cancer. Last year alone, there were 50,000 Americans who were diagnosed with colon cancer. Who died from colon cancer. There were 150,000 new diagnoses of colon cancer. So we screen because while there are many people who have symptoms and will bring their symptoms to the doctor, the most common presentation for colon cancer is no symptoms at all. And so we stratify. If somebody has increased risks, say they have a family history of colon cancer or a family history of colon polyps, we may opt to do their colonoscopies early, but otherwise we start at 50, and then if nothing is found on that first colonoscopy, then the next colonoscopy would be at age 60, would be 10 years from the first one. And say if we found a tubular adenoma, which is a small polyp, we would say come back in 5 years. So there's a stratification depending on what we find.
Is the age where one would start to have a colonoscopy, because we live in such a diverse population in California, say if a person is African American, is there a different age limit where one might start to have a colonoscopy procedure?
Yes, absolutely. The incidence of colorectal cancer is higher in an African American individual, and also their mortality is higher in terms of dying from colorectal cancer. And so we do start screening those individuals at age 45, and that is the recommendation of the American College of Gastroenterology.
Now, I believe you have a chart that you're going to show us that can show different ways to go about looking at the difference between early detection for colorectal cancer and somebody that might already have symptoms or already have had a colonoscopy.
Yes, this was a chart that was put together by the AGA, the American Gastroenterological Association, and this is something that we can show. So if somebody has increased risk for colorectal cancer, we ask them first about their history, and we really should be starting to ask at age 20. And then we review family history every 5 years thereafter just to stay on top of this. So if somebody has a family history, we want to find out the details. Is this a first-degree relative? Was this relative under the age of 60 at the time of their diagnosis? Do they have, and when I say first-degree relative, I'm talking about a parent, a sibling, a child. Or is it a second-degree relative, a grandparent? And so if you have 2 second-degree relatives, that would be significant too. So we have to stratify all of that. And in the chart that's shown, personal history is important. If somebody comes in and they have been diagnosed with inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, those individuals will be screened in a different way because they are at increased risk for colon cancer. The longer someone has inflammatory bowel disease, the greater the risk. So for an individual who might have had ulcerative colitis for 20 years, at that point they are having colonoscopies done annually, looking for dysplasia, looking for abnormal cells. Because when you're thinking about polyps, dysplasia is kind of the road that they follow to become a colon cancer. So you go from a polyp to dysplasia to cancer. In the instance of ulcerative colitis, there may be patches of dysplasia. That's why when we screen them, we take multiple biopsies throughout the colon. And if we find dysplasia, then we need to be more aggressive in that individual. Now, if someone's had colon polyps, if they've had a tubulovillous adenoma or say a villous adenoma, that is more significant than just a tubular adenoma. And so we would have that person come back in 3 years instead of the 5 years that I'd mentioned before. So when you think about polyps, 95% of polyps are going to be either in one of 2 categories. One category is hyperplastic and the other is adenomatous. The hyperplastic polyps, by and large, do not have malignant potential, and they are commonly located in the left side of the colon near the rectum, and they're usually small. And so if you have a hyperplastic polyp, you tell your patient that that's what they have. You say, but that's good news. You don't have to come back for another 10 years.
And I'm sure that is very good news.
That is very good news. And I'm not saying that hyperplastic polyps never turn into malignancy, but it's extremely rare. With an adenoma, and again, 2/3 of polyps are adenomas. So with an adenoma, it could be a tubular adenoma, it could be a villous adenoma, or a tubulovillous adenoma. And then it depends on how many you have. If you have only 1 or 2 tubular adenomas, we would say come back in 5 years. But if you had 3 to 10 tubular adenomas, and some people do, we would say come back in 3 years. If you had more than 10, it would be even sooner than 3 years. So this is all stratified depending on the risks that the individual has. Now, genetics also plays a role. There are entities such as FAP, it's familial adenomatous polyposis, and those individuals need to be followed much more closely. And then there's also Lynch syndrome, and Lynch syndrome is also associated with other kinds of malignancies, ovarian cancer, stomach cancer, brain cancer. And so those individuals need to be followed. And the people who fall into those categories really need to have genetic counseling and genetic testing. And that will also involve their family members who also will need to have some testing. So that's much more aggressive. One other thing I wanted to emphasize is that for some of these people with increased risk, for example, say someone's mother was diagnosed with colon cancer at the age of 52, their son or her son or daughter should be screened at the age of 42. We back it up 10 years from the age of the diagnosis of the individual. So those people will be screened earlier because their risks are greater.
So the reason for screening for colon cancer is
early detection and prevention. Those are the 2 big things, because most of the time a colon cancer came from a polyp. And so you want to remove the polyp so that it can't ever turn into anything. And so that, we're talking about prevention there. Early detection, for example, in someone with ulcerative colitis, we find some dysplasia, we're going to focus in on that. So that's really what all of this is about. All of the testing that we do is for early detection and prevention. That's the key.
So what are the symptoms of colon cancer, though? Say in a patient profile, age 45, healthy, doesn't really have any symptoms. Is there anything that they might notice, or
Okay.
they would think, gee, I think I need to go to my internal medicine physician?
Right. So if somebody's 45 and they have no symptoms, we wouldn't do anything. But the things that people should watch for would be a change in bowel habits. For example, maybe they've never had issues with constipation, but now they're becoming constipated. Or maybe they're having diarrhea. Maybe they're having constipation alternating with diarrhea. Maybe they are having a change in the appearance of the stool itself. Perhaps it's kind of a pencil-thin stool, and something that they normally don't notice, but this has changed, and so that would be a reason to consult a physician. Unintentional weight loss. Say somebody, has always had issues with weight, and suddenly they're losing weight, and they're not even trying. That's a red flag, and so that would need to be brought to attention. Abdominal pain, various types of abdominal pain need to be evaluated. Somebody might present with anemia, in particular iron deficiency anemia. Why are they iron deficient? Is it because they are slowly losing blood into their colon, and that's the reason for it? And if somebody's having rectal bleeding, whether it's bright red blood or dark red blood, that's certainly a reason to come in for an evaluation, because that might be a sign of colon cancer.
Now, let's discuss colonoscopy. I think everybody is afraid of having a colonoscopy versus having a sigmoidoscopy. But what is the procedure, the prep for colonoscopy? And let's discuss exactly what a colonoscopy is.
Okay. Well, a colonoscopy involves inserting a flexible scope, a long flexible scope, into the rectum and winding it up through the colon. And I can show you that you're going to start in the rectum. The rectum is the distal 6 inches of the digestive tract, and then and of course this is fiber optic, so this is a very flexible scope. And
is that where polyps can often occur, in that distal section there?
Yes, very commonly, polyps and cancer. And so you're going to thread your colonoscope, which bends very easily, into the sigmoid colon, and this is often an area where there's diverticulosis as well, into the descending colon, up to the splenic flexure. And when we talk about flexible sigmoidoscopy really only looks at a third of the colon. And so a flex sig is going to stop at the splenic flexure. I mean, you would hope to get to the splenic flexure with a flex sig. So with the colonoscopy, you're going beyond that. So you're going to look at the transverse colon, then you go around the hepatic flexure, and you go down to the cecum, which is the very end. The cecum is what connects to the small bowel. And you can also sometimes intubate the small bowel. And in fact, in patients who have inflammatory bowel disease, you want to do that just to see if there's any inflammatory condition in the terminal ileum. So that's the entire area that's looked at with a colonoscopy. You're not looking at the liver or any of the other organs, just the mucosa of the colon itself. And in order to do that, in order to get a good look, you have to have a really good bowel prep. I mean, I can't emphasize that enough. If the prep isn't good, you're going to miss things, and that's what you would hope to avoid.
Are there different types of preps?
There are different types of preps. The Go Lightly prep that we've had for years and years is a 4-liter prep, and that's the prep that we still use at the hospital. And we give it in a divided dose. That's what is recommended. The prep is better if you take it that way. So we usually start the first half at about 3 or 4 o'clock in the afternoon, the day before the test, and then the second part is given 3 to 5 hours before the actual procedure is done. And we don't want it to be 7 hours or more before the procedure, because there is effluent from the small bowel that then creeps into the right colon, and your right colon isn't as well visualized. So that's one of the reasons why we say, okay, let's make sure that we take that prep 3 hours, 4 hours beforehand, no more than 5 hours before the actual procedure. And the other thing about it is that the day before, you will either be on clear liquids all day, or you will have a breakfast, a low residue breakfast, and then be on clear liquids the rest of the day, so that you have less to clean out.
Is there not a pill form that you can take as well?
There is a pill form. There's Osmoprep, And I know people say it's one pill. They think it's one pill when they come in, and I say no, it's 32 pills. And the pills are somewhat large, so somebody has to be able to take pills to take that one. But we start in the afternoon the day before. They take 4 pills, wash it down with clear liquids, wait 15 minutes, take another 4, wash it down with clear liquids, wait 15 minutes, until they've taken 20 pills. And then that's going to start things moving through their digestive tract. Then they take the remaining 12 pills the following day before the procedure. And so that would be 4 pills, wash down, wait 15 minutes, another 4, wait 15 minutes, another 4, and then they're done. And that should get them cleaned out. There are some patients who have redundant colons or unusually long colons that might need more than the usual prep. And some people even need 2-day preps to be cleaned out, or they'll come in, we'll attempt to do the colonoscopy, but the colon is not sufficiently clean, so we'll have them re-prep again and have them come in the next day, because the prep is really important.
Now, as a patient, what can a patient expect during a colonoscopy? They've done this prep, and obviously it needs to be timed extremely well, so you need to be having the procedure done within a certain period of time. But what can they expect exactly?
Well, some patients are worried that it's going to be painful, so we always tell them that they will be receiving sedation, Versed and fentanyl, and sometimes Benadryl. That's what we give. Some centers also use propofol, which is a general anesthetic. What we use is conscious sedation or moderate sedation, so it's not painful, and it's adjusted for the patient. We don't want to give them more than they need, but we want them to be comfortable. And the procedure itself is really pretty quick. I mean, it typically takes 15 to 20 minutes to do a colonoscopy. When we come back, we don't want to rush ourselves. We want to be able to, in a circular fashion, look through the colon, because there are lots of folds in the colon. It's easy to miss something in the colon, especially in the right colon. So we need to take our time. So we don't want to withdraw the scope any faster than 6 minutes. So we're going backwards, looking, and we may have seen something coming in that we need to address as we're coming out. And so we're looking with our fiber optic scope, and we also have high definition scopes. And so the views are much better than what we had, say, 5 or 10 years ago. And after the procedure, we do, by the way, put some air in so that we can get a good look. We want to expand the colon so we can get a good look. And if we have to work in the colon and take out a polyp, we need to have it expanded too. So we will withdraw some of the air, but the patient will still have air to pass afterwards. But most of that air is passed within a few minutes of completing the colonoscopy.
So can the person that is having this procedure, can they actually see that on a screen while this is being performed if they wish to?
Some people do, and if people are waking up as we're withdrawing the scope, we typically don't give them more medication, because say if we find a polyp and we're going to take that out, it's not painful for the patient, and so they may watch it. Now it depends on the patient. If they don't want to watch anything or see anything, they don't have to. We're fine with that. We can give them further sedation. Some people say they want to be out for the whole thing. So basically we go with the patient's wishes. Some patients have come in and have requested to be awake for the whole thing. And we will try that, and some patients are successful doing that. Sometimes we'll start and they'll say, well, I've changed my mind, and then we go ahead and give them medication, sedation, and it's, they have an IV in place, so administering additional medication is very easy.
So after the patient has had this procedure done, I would assume that they rest for a little while?
Yes.
In a lab where they
Well, we keep them in our endo center for an hour after the last sedation medication has been given. And they get a little bit of something to drink, cookie, crackers, whatever.
That's their reward.
That is their reward. And we want them to be sufficiently awake so that even though we're taking them down to the car in a wheelchair, we want them to be awake enough so that they can get into the car and be taken home by somebody that they know. And some people take a little bit longer to wake up than others, but we give them something to eat before they leave, and we usually will tell them something about the procedure. But they may or may not remember it because Versed has an anamnestic response, and so they may not recall a conversation that they had with the nurses or physician while they're in the endo center. That's why I always call them later on that evening, because they're going to go home and take a nap and sleep it off, and they go home with a copy of their report, and so they can read through that, and then I call later so they've had a chance to do that. So if they have questions, we can go over everything at that time while they're fully awake.
And then can a patient return to work, their normal activity the next day?
Yes, the next day. We don't want people driving or signing medical or legal documents, any legal documents after having a colonoscopy, after they've had some sedation, but the next day is a regular day for them.
So what are the risks and the benefits of a colonoscopy?
Well, the benefits are having polyps removed if they're there. And I want to emphasize, polyps are common. If you were to take the average male who comes in for a screening colonoscopy, has no symptoms of screening, the likelihood of finding an adenoma is 25%. A woman coming in for screening has a likelihood of finding a tubular adenoma or an adenoma of 15%. So it is a little bit more common in men than in women. But it's a very common finding. And so the good news is that if they have these, they're removed. And so their risks for developing colon cancer have been significantly decreased, and they're now in a pool of patients who need to be surveyed, who need to be followed. And so we would have them come back in 3 to 5 years for follow-up. And so that risk has been removed from them. And so that's good news for them and for their families. In terms of risks of the procedure, I view colonoscopy as a low-risk procedure for most individuals. There is a risk of bleeding. There's a risk of perforation. Because we give sedation, there's always a risk that there could be some cardiopulmonary adverse event. But we try to stratify those things. I mean, there are some people where if they're older and they're at risk, we will, instead of doing them in the endoscopy center, we will do the colonoscopy at the hospital so that we have more backup help. But we have lots of things that we can do if something, for example, if a polypectomy site starts to bleed, we have clips that we can put on the site. And we try to decrease our risks by asking patients not to take any aspirin or nonsteroidals, for 5 to 7 days prior to the procedure. So that helps us decrease the likelihood that there would be an effect on the platelets, and that hopefully their platelets would work and they would clot. And when we take out polyps, there are 2 major ways we take them out. One is just with biopsy forceps. We can do that with the smaller polyps, or we can use the snare. And the snare is used for larger polyps. It can be either a hot snare or a cold snare. And we're doing much more with cold snares now than we used to. There are some risks in using a hot snare in the right colon. The cecum and the right colon, and I'm talking about this area here, cecum and right colon, are thinner than the rest of the colon. And so there's some concern about using cautery over on that side. And so we often would opt to just use a cold snare to remove polyps over in that section.
And does it matter where the polyps are located in the colon? Is one area more serious than the other, or is it really based on the size of the polyp and whether it's hyperplastic or a tubular?
Pathology is big. The size of the polyp is significant. If we think of a large polyp as being a centimeter, and if it's greater than a centimeter, the risks that it might even contain a cancer are higher, and you would bring somebody back earlier if they had larger polyps.
And what is the difference between diverticulosis and diverticulitis?
Diverticulosis just means the presence of pockets in the colon wall, and it's something that you don't see in someone who's 20 or 25 years old. It's something that crops up as you get older, probably just from increased pressure in the colon, and so you might see it in someone who's, say, 50, 55, 60 and on up. More common, you see it more commonly as people age. and they may develop more of them. Once you have them, they don't go away, but you would hope not to form more. So we tell people it's a good idea to be on high fiber. And diverticulitis means, the word itis, the ending itis means inflammation. So that means that one of those pockets has become inflamed. And so if somebody has diverticulitis, we like to get them started on antibiotics as soon as possible, typically ciprofloxacin and Flagyl, so we're covering for gram-negative organisms and anaerobes. And it's very possible that sometimes an abscess can actually form. And so some people require a diverting colostomy or surgery to manage that particular problem.
If a person was having an attack of diverticulitis, would they actually know that they were having that attack?
They might not know, but when someone has a colonoscopy and you see diverticulosis, you tell them, because they go home with a copy of their report and they know that they have diverticulosis. And so you make the point that if they ever had abdominal pain, or in particular abdominal pain and fever, one of the first things they would think of is diverticulitis, and they would need to contact us.
And what are the risk factors for colon and rectal cancer? I know we discussed them earlier, but can we just go over those again for everybody? Because I think it's really crucial.
Well, and this also ties into things people can do to decrease their risks for colon cancer. I mean, risk factors include hereditary issues. So that's something if your parents or grandparents, or if your parents had colon cancer at a young age, that's a risk factor for you. But obesity is a risk factor. And, you know, in the algorithms, obesity isn't put into the algorithm, and so you sometimes have to kind of add a few extra things into your own algorithm for that particular patient to decide how you're going to follow them. Because obesity is a risk factor, we tell people they should try to maintain, you know, a normal weight, and of course, you're at greater risk if you're not exercising. So we emphasize exercising on a regular basis. And some people will actually do screenings on obese patients every 5 years instead of waiting 10 years. Say if their procedure is negative, they might say come back in 5 or maybe come back in 7. They might not wait the full 10 to have them return. Another consideration is multivitamins that contain folic acid. That's felt to be beneficial in terms of hopefully decreasing the risk for colon cancer. Calcium, and also vitamin D3. There's a big focus on vitamin D deficiency now, and decreasing the risks for colon cancer is also one of them. Another element that has been discussed is selenium. And so selenium might also be decreasing the risks for colon cancer.
And what should the diet contain? I know you mentioned earlier high fiber.
High fiber.
What do you consider high fiber?
High fiber would be fruits and vegetables, grains of all types. We would steer away from red meats. So we would steer away from, beef, pork, lamb. And for people who really feel that they can't cut that out of their diets, we would say try to limit it to 2 3-ounce servings per week.
And that's about the size of a card, a playing card?
Yeah. And so those are the limitations. I mean, red meat is definitely a risk factor. And other risk factors, smoking and also excessive alcohol intake. Smokers increase their risks for colorectal cancer by 20%. And so when people come in to the office who are smokers, we really make an effort to get them into a program to stop smoking because, it decreases their risks is one more thing to consider.
So pick your poisons and pick them well, as
exactly.
they say. What other type of screening tests are available for colorectal cancer?
Well, the gold standard is colonoscopy, and that's what you would hope most people would choose. But there are many people who don't want to go that route, and so there are other things to do. Now, the guaiac test for occult blood has been around for a long time. And there are 2 different kinds of guaiac tests. One is is more sensitive. That's called the Sensa test. And the other one that's not very sensitive probably shouldn't be used at all. And if you do that, then use the Sensa test, then you should be testing every year. And that is not as good a test as the other tests that we would recommend. Now, there's also something called an air contrast barium enema, and that's been around for a long time. And if somebody wants to opt for that, then they do that every 5 years. And what it is it's barium that's placed as an enema, and then air done right after that, so that there's kind of an air outline of the colon wall. And you can pick up larger polyps, but this is not as sensitive a test as a colonoscopy. And so the likelihood that most people would choose that option, I think, is low, because the patients are awake and it is a little bit more uncomfortable. So most people wouldn't choose that. Sometimes if you do a colonoscopy and it's impossible to get to the end safely, then while they're cleaned out, we may send them over to the Department of Radiology to have a barium enema to look at that last portion that couldn't be visualized. There's also something called a virtual colonoscopy. And that's like a glorified CT scan. You know, it's what they've been able to do with CT scans and computers. And there are risks and benefits to that. There's no sedation. So if somebody has significant pulmonary disease, they can still do that test. However, they do need to take a bowel prep, and that's what everybody hates. So you still have to do the bowel prep for that. Another negative for that is that you have radiation exposure. And so there are risks with that. And if you do that kind of a test, we say, okay, do it every 5 years. And then there's also the stool DNA test, which has just recently become available. It was approved by the FDA in August of last year. And that test is available through Exact Sciences in Madison, Wisconsin. And so you don't even go through your local hospital. I mean, the physician writes out the order and sends that in to Exact Sciences, and they contact the patient directly. They do the test at home. They provide a stool sample that they then mail to Exact Sciences, and then they give us a result back. But this is to pick up. It's a reasonable test for picking up cancers. It's not a good test for picking up large polyps. So colonoscopy is actually better, but if any of these other screening tests come back positive, then the patient has a colonoscopy.
As the medical industry is changing, do you see changes within the next 10 years in how colonoscopies are done? Do you see any new equipment that's coming out on the market, or any easier ways for this to be done for people?
The equipment is always getting better, and the preps are always getting better. And hopefully in the next few years we'll have a better tasting prep. There is a prep called Prep-A-Pick that's pretty good tasting. It's cranberry and it's orange, but it leaves a little bit of a film on the lens of the scope, so they're still working a little bit more on that. We tell people if they want that prep, they need to drink more fluids. And we want people to be hydrated for the test anyway. But the fiber optics of the scopes is always getting better. High definition scopes, you know, how well we can actually see some of these pits in the polyps. I mean, that's always improving. And some people are doing propofol, which, you know, I mean, they wake up faster, they're out of the endoscopy center much faster. Some people prefer it, some people don't. Our center does not do propofol, but some centers will do both propofol and the Versed and fentanyl. But it's a painless test, and you know the standard response is, "Are we done?" Because we'll say we're all done. And I go, "You're done? When? I mean, I don't remember anything." And so that's the typical story.
Is colon cancer preventable?
It is preventable because you want to get those polyps. And so you get those polyps early and you get them out of there, and so I'd say it's not 100% preventable, but the prevention is high, and early detection is part of the key too, and that's what our goal is.
And is it beatable?
Yes, that's why I would encourage people to go ahead and do these colonoscopies. you know, your family will thank you for doing them, and you will be thankful that you did it. I mean, some of these people come in thinking they have nothing, they don't have any symptoms, so why are they doing this? And they come in and they have a premalignant polyp, and they're very grateful and happy that they decided to go ahead.
Dr. Skaar, I want to thank you so much for coming to visit with us today.
Thank you.
And for really explaining how the whole process goes of having a colonoscopy, and for people to know that this really can be a treatable and beatable disease condition. I want to thank everybody for watching today, and I urge all of you, if you are over the age of 50 and you have not had a colonoscopy, please contact your internal medicine physician and look at all the options that you do have out there, because beatable, treatable is a wonderful way to go. Live each day, life is so very precious, and thank you so much for joining us today.
This program was made possible with the generous support of the Magnolia of Millbrae. The Magnolia of Millbrae is a senior living community that provides a variety of services and amenities to its residents. For more information, call 650-697-7000 or visit their website at www.themagnolia.com. MCTV thanks them for their support.